I'm Dr Alistair Blair. I'm the Clinical Chief Officer of Northumberland CCG.
Now explain for people what a clinical commissioning group is, what your actual role is.
Clinical commissioning groups are basically there to make sure that the taxpayers' money is allocated to Northumberland and that we spend it in the best way for the population. So it's particularly around hospital services, making sure we fund the hospital services and making sure that they're the right services for the population.
Now explain the bed occupancy rate here in the inpatient ward and why you've come to the decision that you have.
Well, over the years, there's 12 beds here in Rothbury, and we've seen that there's been gradually that the number of beds that have been used on average has decreased. Certainly in July, we were seeing that there were only on average 4 out of the 12 beds being used. And when you look at the stresses within the NHS, that degree of empty beds when we know other bits are busy just doesn't make a lot of sense.
So is this a cost-cutting measure, or is this actually a clinical decision?
I think this is both, to be honest. The first is that if you've got really low numbers of people in the beds, you can't put all of the support services around them in the way that you want. And we want people to be home as quickly and as safely as possible, and that needs whole teams of people supporting them. The second thing is that clearly if you've got loads of empty beds and you've got full staffing, there are costs associated with that, and we can actually use those nurses to actually help in other parts of the healthcare system in Northumberland.
Now this was announced a week ago. There's been a very rapid clear out, hasn't there?
Well, there weren't many patients in the first place, but there has been real care about those patients, some of whom are due to be discharged, and certainly one who's being transferred out of it. And it's really important that that's done as sensitively as we possibly can do. But I think also that when you've got, it's very different if you were closing a full ward to one where there aren't many people in the first place.
Now for that 89-year-old terminally ill lady, this has been a bit traumatic, hasn't it?
I'm sure it's been difficult for her, but I think the other thing that we've got to look at is, can she get really good care in other parts of the whole of the Northumbria health system, and I'm sure she'll get excellent care whichever one of the wards she's on.
Now, it's a 3-month temporary closure. You talk about public consultation. What form will that take?
Well, I think there's two things. That this is a temporary closure, which happens all the time. Wards are closed throughout the NHS on a regular basis, particularly in summer months when they're quiet. We then need to think what we do. If there are proposals, we need to consult on the proposals, but there are no proposals at the moment, so you can't consult when you don't have things to ask the public questions about.
Okay. Obviously in 3 months' time, beginning of December, winter pressures, presumably you would have thought in this isolated remote community there might actually be pressures to reopen this inpatient ward.
And we need to look exactly at that sort of situation and how you make best use of all those beds. What we have seen is over the years, though, and it's partly seasonal, but also even in the winter months, some of the beds, particularly given the investment we've had in the new hospital in Crampton, people are getting home quicker, be it winter or summer. And what we've got to do is, I think, move away from the idea that hospitals are judged by the beds that they've got within them, to actually hospitals being judged by the services that they provide for their communities. And we've got to get more services out to really support people, because I know that there are people who are iller in their own homes than some people who are in particularly some of the community hospital beds, and we've got to do the right thing for all of those patients.
Now, closing a ward, then consulting on the closure, it doesn't look like it's going to reopen, does it?
I don't think anybody's saying it's not going to reopen. I think suspending a ward is done all the time. It's routinely, there will be wards closed on a routine basis all the way across the NHS. It is unique that this is the single ward in a remote community, and I fully understand the feelings about that. But you've also got to bear in mind it's probably the most empty ward in the whole of all of the beds in Northumbria, and you've got to treat to a degree the fact that there are still loads of costs associated with that. And we've got a duty to make sure that we're spending the money right for the whole of the population of Northumberland, not just in isolation. It's got to be everybody that gets the best deal.
Now, talk me through the decision-making process that led up to the announcement last week that you're shutting this temporarily for 3 months.
So when you run an organisation with nearly 1,000 beds, we're looking at how our beds are used all the time. We've made a number of decisions about which beds are open and closed and moving them around. And on the basis of the occupancy of the beds, which has been dwindling at Rothbury, we've taken a decision, along with our colleagues in the CCG, to temporarily suspend admissions to Rothbury, just whilst we look at the overall picture of what is best to do.
It was a very rapidly taken decision, wasn't it? It was a surprise for both patients and staff.
Yeah, the numbers have been dwindling. As you know, we've been taken part in a number of processes the sustainability and transformation process, which has made us look at our assets and how we're using all of our beds. So it was as a result of those processes that the dwindling numbers of patients at Rothbury came to light.
Now, you said it's a temporary closure. Does that mean you're going to reopen on December the 1st when the winter pressures start?
What that means is that we're going to look at the situation and we're going to see what the best use of resources are for Rothbury. And as we stand here today, Age UK, the Alzheimer's Society, will tell us about the dangers and difficulties of having people stuck in beds. We've invested a lot of money, and that's probably one of the reasons why the numbers are dwindling, a lot of money into services that prevent people needing to be in hospital and getting them where they really need to be, which is at home.
So where are these inpatients going if they need inpatient care, if they can't come to Rothbury?
So there are other similar facilities around. That can sometimes be to nursing homes or to Alnwick Infirmary. But the vast majority of people from Rothbury who are currently in, and this has been true over the last year, who are in beds are because they're acutely unwell and they're in our main sites receiving intravenous antibiotics and treatments for their illnesses. And those are the sort of services that we can't quite deliver here.
Now, one of your last patients is an 89-year-old terminally ill woman who's being shuffled out the door at haste. It's a bit unseemly, isn't it?
Well, of course, it is very difficult once you've made a decision for the individual patients. We've spoken to the family, we've spoken to the lady, and we've tried to minimise the disruption as far as possible. But you're absolutely right. It isn't ideal that we should be transferring people in the middle of their stay. However, it has only affected a very small number of people. And that is when we make any bed suspensions or moves, which we do, as I said, right the way across our system, one of the inevitable consequences of how our nursing staff numbers change on a week-to-week and a day-to-day basis.
How many staff have been affected by this, and where are they going to go?
Yeah, so that will be part of the review. So as I understand it, there are 12 staff that are affected who work on the ward. There's obviously a lot of staff who work in the other facilities here. There's a paramedic ambulance station. There's a whole outpatient facility who won't be affected by that. And that will become part of the review. And that's because we'd got to a situation in the month of July when there were only 30% of the beds being used, and it would be absolutely normal business under those circumstances for us to look at redeploying resources. For a number of years, though, we've built this fantastic facility here. We've been trying to make the very, very best use of it. But also, during the last few years, we've been conscious that our success is not judged by the number of beds that we have. Our success is judged by how many people we return healthy to home. And that has changed. We've invested an awful lot of money in the services that are designed to get people home early.
Now, as you say, this is not even 10 years old, this hospital. It's a PFI hospital. You're paying a substantial amount of money, but it won't have an inpatient ward. Is that good use of resources?
Well, that is absolutely something that we'll need to look at in terms of the review, but clearly we're unable to use the beds adequately. At the moment, the occupancy has been 50% pretty steadily and dwindling over the last 2 years. It rarely has been above that. And as I say, in recent months has fallen below that. So we'll have to look at that in the round. We have a 25-year contract and there will be a hospital at Rothbury. It's a really important community resource. How the beds are configured in this building is something that we're going to need to look at.